But today our topic is on nutrition and mobility, specifically looking at aging, muscle health, and dietary intake. My name is Amanda Wilson. I'm a physical therapist and a teaching assistant professor at the University of North Dakota, and I teach in the PT program. I practiced for 16 years in the clinic in a variety of settings, including acute care, the rehab setting, outpatient. I specifically have interests in working with the older adults, geriatrics, also neurologic diagnoses. So I'll go ahead and pass it on to Nathaniel. He can introduce himself.
All right. Hi, everyone. Yep, it's great to be here. I'm Nathaniel Johnson. I am an assistant professor of nutrition and dietetics, also at the University of North Dakota. My PhD is actually in nutrition and exercise science, and my dissertation was about dietary intake and ways to enhance muscle health. So this is a topic near and dear to my heart, and I'm hoping to share some of that excitement and passion here today. And with that, I'll let Amanda take things away.
All right, thank you. And I really appreciate having you along, Nathaniel. It's been great. So the objectives here today, we're going to discuss the importance of adequate nutrition in relation to strength and mobility with the older adults. Also looking at some of the specific nutritional requirements, and then look at the appropriate strength, nutritional, and food insecurity screenings that we should be considering for all older adults. Also recognizing the importance of referral to a dietitian for individualized needs. And finally, applying the knowledge of nutrition and mobility with a case, which we'll actually start with here in the introduction. I'm going to read it out loud. You're welcome to read it along with me, just to give you a picture in your head of this person who we will discuss in the end as well. So this is Mrs. Smith, a 70-year-old retired teacher who lives alone in a suburban community. She has a history of osteoarthritis in her knees, which limits her mobility and makes it difficult for her to engage in physical activities. Her husband passed away 5 years ago, and she has been living independently since then. Mrs. Smith enjoys cooking and gardening, but has recently been experiencing some challenges in maintaining a balanced diet and staying active due to her arthritis. Mrs. Smith's diet consists mainly of convenience foods and processed meals because she finds it challenging to stand for long periods to cook. She tends to skip meals or opt for quick snacks instead of proper meals. Her diet lacks variety and often lacks essential nutrients. Due to her limited mobility and reduced strength, she has experienced some unintentional weight loss over the past few months, which further exacerbates her weakness and fatigue. She used to enjoy gardening, but now finds it difficult to kneel and bend due to joint pain. So some of you may have had patients in your past experiences similar or with some of these impairments. So you can maybe also picture that patient as we go through. So I'm going to begin just by discussing some of the muscles and strength changes that occur over time. This figure here depicts the change in muscle strength, also looks at some other measures of strength and compares those within different ages. But this is a 10-year longitudinal study looking at that change over time. And so you can see here in these 30 to 50 age time frame, the strength plateaus. And then as we go further into the older ages, we can see the strength changes decline over time. Along with this, that's important to understand its muscle mass and strength. And more specifically as well is that older adults tend to lose the greater amounts of type 2 muscle fibers, which are those fast twitch muscle fibers that help with the power, the short acting muscle activation needed to get a lot of strength all at once. And you can see here in this study, one of those examples is the chair stand, sit to stand. And if we look specifically at the diagnosis of this, sarcopenia is the definition of this progressive loss of muscle mass and strength with age. In the picture, you can see this is a 25-year-old healthy adult as well as a healthy 75-year-old. And that just shows the change in the proportion of muscle to fat. When we look at the diagnosis of sarcopenia, it's looked at by 3 different traits, and that would be the decreased levels of muscle strength, muscle quantity and quality, also physical performance. Also important to note that there's a new ICD-10 code for sarcopenia as of 2016, which I think will just help overall in identifying those patients when we look back in the charts and for our treatment. Then here we look at the importance of the skeletal muscle and strength. So piggybacking off of the idea of sarcopenia, if we look at that and look at the odds ratio with mortality, those with sarcopenia are going to have a 3.6 times more likely or greater risk of mortality. And then looking at disability is 3.03 times greater risk of disability. Along with that disability comes increased risk for fracture, injury, also reduced quality of life. Here, this 40 to 50% of body weight, that is indicating we're looking at the overall body makeup of our bodies in the adults, and just emphasizing that's the skeletal muscle, how much muscle is in proportion of our body weight, 40 to 50%. So it's a large portion. Along with that, the skeletal muscle has about 45% of the total body proteins. And so the muscle, it's also an important amino acid reservoir holding those building blocks for protein. Important to note here, if there's trauma or a negative energy balance within the body, that is going to cause, meaning there's a greater expenditure of energy versus energy intake of energy. And so that will cause more of that catabolism or that breakdown of the muscle, because our body needs to find that energy somewhere, and it's going to go to the muscle to find that if there's not enough nutrient intake. And I think this emphasizes the importance of what we'll be discussing today, the nutrient intake and the requirements for the older adult, which are much more sensitive for the older adult than the younger age groups, which Thani will go into a little bit more detail here. Along with these factors we just talked about, there are other diagnoses that are related to decreased strength to consider. And we know with the older adults, there's the factor of comorbidities, things like diabetes, cardiovascular disease, impaired cognition, Alzheimer's, disability, and death can have that decreased strength related to it. And with the picture here, just considering these mediators and the third factor mediators, which can have parallel effects. So one change in function can also impact another as well. This one comes directly from Dr. Johnson's research. So if you have anything to add to that, you can go ahead with that.
I mean, I suppose there's not really a lot I'd like to add other than a reiteration that I realize that I'm talking probably mostly to physical therapists. It's a little bit like preaching to the choir, but physical strength and muscular strength is a lot more of an indication than just someone's ability to move something heavy, right? So a decrease in somebody's hand grip strength, which is a great tool because you can bring a hand grip strength dynamometer right to a patient's bed. Most patients or participants can complete a hand grip strength dynamometer test. In any ways, decreases in hand grip strength are related to things like diabetes and all these other things on this list. And I think the most surprising ones are impaired cognition and Alzheimer's disease. But we need to consider, right, that the muscular system is actually the neuromuscular system. And so there's an indication here that, decreases in muscle strength could also be related to changes in neurological factors as well. And of course, nutrition, which is what I'll be talking about more, is related to both neurological and physical factors. So a great way, a third factor that can address both of those. And I'll end there, Amanda.
Yeah, and I would add to that too, just the changes that happen with cognition and being involved with activity decreases with that change in cognition. So you can definitely see the tie there. And lastly, just to look at, we talk about the body, the makeup of the body. We also can look at BMI. There's a lot to this chart, but most significantly, I want to look over at the right-hand side here. So this is looking at different BMI groups with the vertical dashed lines. And if we look at the way the graph goes here, showing that there's this is looking at injuries and external causes of mortality. And this top one is the full study population. So that one's probably the most appropriate to look at here. But these lower BMIs actually have a higher risk of mortality. So, and you can see over here, higher BMI, lower risk. And so the consideration that we're always thinking we should have BMI be low may not always be the case. There could be some protective factors in having a higher BMI. It's really, there's a lot of factors that go into this, but just having just the thought that maybe different age groups, we want to consider different BMI levels or higher BMIs might be better or more protective. And then finally, there's a lot of contributing factors to muscle strength, power, mass. We can look at age and gender, different changes in the neural system, even hormone changes, and overall comorbidities and activity. Today, we're going to be talking most specifically about nutrition and dietary intake. So just important to remember it's multifactorial, but today we're going to focus in here. So I'll let Dr. Johnson take over and just let me know when you need to advance and I'll move it forward.
All right, thanks, Amanda. Yeah, so to tie things, around in kind of a bow, we're going to be talking a lot about dietary protein in just a moment, which goes back to our amino acid reservoir, which relates to BMI. If you have a bigger BMI, assuming constant proportion of muscle mass, you're going to have a greater amount of amino acid reservoir that should be protective against mortality related to things like external injuries. And anyways, that's what we see in that research, and it's pretty cool stuff. Regarding dietary intake and aging, some things to consider are, as we get older, taste decreases. This is something we're going to return to later on in this little webinar. Oral health worsens, and our ability to chew or masticate also decreases. All of these negative changes lead to dietary intake decreasing by about a quarter from age 40 to age 70. So because dietary intake decreases, this is going to predispose older adults for nutrient deficiencies, in particular if they also have increased nutrient needs, which they do. On top of those nutrient deficiencies or decreased intake, older adults' energy expenditure decreases as they get older. So this means that older adults, if they're eating too much energy, too many calories, they'll actually have an easier time gaining fat tissue, which can result in something more problematic than just sarcopenia, which is sarcopenic obesity, which is essentially low skeletal muscle mass and strength coupled with obesity. Amanda, we go ahead and
Okay.
So as I mentioned, dietary protein, we're going to be talking about a few different nutrients today as an area of focus. Dietary protein is the most important one of these nutrients, though, because dietary protein can directly stimulate muscle protein synthesis. So this gives us a clear route for how dietary protein can aid in things like muscle mass and strength. Specifically, dietary protein and amino acids, leucine is going to be the most anabolic, but leucine, arginine, methionine, they all have amino acid sensors related to the mammalian target of rapamycin complex 1, a ubiquitous protein complex that controls translation, the production rate of proteins from messenger RNAs. So essentially, without this protein complex, we don't have translation. Translation means more proteins per messenger RNA. This means more muscle protein synthesis. And right, the advantage here with dietary protein is it directly activates this mechanism, again, giving us a clear link to how dietary protein can benefit muscle mass. Keep going, Amanda. Thank you. So there are 3 keys to dietary protein success I'll be talking about today. The first one is, of course, quantity. We hit the arrow for me, please. So we're going to start off talking about the effects of aging on the amount of protein that one needs to maximally stimulate muscle protein synthesis. And the point there really is, as we get older, folks actually need more protein to maximally stimulate muscle protein synthesis. So panel A and C are the comparisons. This is grams of protein per kilogram of body weight. So B and D are standardized per lean body mass. A and C are not. And this is differences between a group of younger men on the bottom and older men on the top. And we see that older men require an average of 0.4 grams per kilogram per meal to maximally stimulate muscle protein synthesis, whereas younger men only need 0.24 grams per kilogram per meal. So it's actually a pretty big difference in the amount of protein needed per meal to maximally stimulate muscle protein synthesis. Will you roll the slide, please? So on top of older adults needing more protein to get the same benefit regarding muscle protein synthesis, equally bad news is the anabolic response to exercise, namely resistance exercise, is also blunted with aging, meaning people produce less muscle with the same exercise as we get older. So now we have a double whammy. Older adults need more protein and, in many ways, more exercise to get the same response regarding muscle protein synthesis. Amanda, will you please? The good news is that protein intake after exercise alleviates this difference. So this is data between young and elderly folks, either between a meal and resistance exercise or just a meal alone. And what we see is that there's not a difference between young and elderly participants when given a meal with resistance exercise. So this illustrates that protein intake and resistance exercise are critical aspects to maintaining muscle mass and strength as we get older, which is probably a no-brainer for most of the folks here in attendance, but here is the hard proof or the evidence of that. Will you please forward the slide? Thank you. What's more interesting to me as a nutritionist is the overall protein recommendation. So currently the National Institutes of Health, recommends 0.8 grams per kilogram per day. However, going back to our previous research looking at older adults we just talked about, they maximally benefit from an intake of 0.4 grams per kilogram per meal. Assuming 3 meals per day, well, that comes out to 1.2 grams per kilogram per day, which is well in line with, experts in muscle and health, their recommendations for protein intake as we get older. Other folks recommend, instead of an amount based on someone's body weight, a more general amount, which is 25 to 30 grams per meal. Amanda, please. So this leads me to my next point here, which is protein distribution. So the same studies that inform this 0.8 gram per kilogram per day recommendation actually only included works where participants ate isonutrient meals. An isonutrient meal is a meal that has the same exact nutrient content. So protein intake was actually exactly evenly distributed. These people ate the same amount of protein for breakfast, for lunch, and dinner. And on top of that, they ate at least 3 meals a day. In some of these studies, they ate 5 meals a day of the same amount of protein intake. Well, breakpoint analysis, what we just talked about, indicates that only so much protein at one meal can actually maximally stimulate muscle protein synthesis. So in other words, we shouldn't be eating all of our protein at once. And the recommendation for 0.8 grams per kilogram per day is going off the assumption that we're exactly, perfectly, evenly distributing our protein intake, not eating too much at once. Next slide, please. Well, this is an area of research that I explored for my dissertation, and it's well back. This is my research, but you can find, research from NHANES or other rich public data sets that are going to support this. Well, we took a look at protein intake at breakfast, lunch, and dinner under free living conditions. So these are just folks eating meals, right? Well, look at how much protein they have for breakfast, 17.4 grams. At lunch, it's up to 28.1. And at dinner, it's close to 40 grams. As a percentage of their daily protein intake, people get about 20% at breakfast, about a third at dinner, and the remainder, about 47%, at dinner, they get about a third at lunch. So the point I want to make here from this set of data is that really people do not eat isonutrient meals. People do not eat the same amount of protein for breakfast, lunch, and dinner. So when it comes to protein intake distribution, will you advance the slide, Amanda? We found that those who had more even distribution in our study had increased amounts of lean mass, higher hand grip strength, greater lower body summed strength, so greater lower body just total strength, and greater lower body endurance. So dietary protein distribution is definitely part of optimizing somebody's response to dietary protein. In other words, we can eat less dietary protein if we have perfect distribution. Nonetheless, right, the current research in older adults would suggest that older adults have increased protein needs than younger adults. So we're looking at, again, at about 0.4 grams per kilogram per meal for older adults, or if you're looking for a more general number, 25 to 30 grams of protein per meal. Will you advance the slide, please? Okay, so we talked about the first two of these. Now we're going to move on to the last key to protein success. That's dietary protein quality. If you would, please. So dietary protein quality is an objective measure that we can make in the field of nutrition. This is done using animals. It's actually a really complicated process, and I could get into the weeds here if you'd like me to. But basically, it's an objective score ranking dietary protein quality, being complete proteins, good proteins, and poor quality proteins. So complete proteins have a score equal to or greater than 100. Good quality proteins, 99 to 75. And poor quality proteins have a value of 75 or below. And what this research is showing here are the protein quality scores for things like pork, casein, that's part of milk protein, egg protein, whey protein, another component of milk, potato, soy, canola, pea, lupins, rapeseed, oat, and so on. And what this research shows is objectively, from dietary protein quality standpoint, using, our objective measure in our field, this would be the digestible indispensable amino acid score. Animal proteins, this includes dairy and eggs, which would be vegetarian, have complete protein quality, whereas only soy and potato, interestingly, are plant sources that are complete proteins. Most plant sources of protein, when we talk about plant protein power, plant proteins are helpful for a lot of reasons. But generally speaking, it's not due to their superior dietary protein quality. These are generally higher or better in animal foods, namely dairy, milk, and meats. You can advance the slide, please. So in light of that, and looking at what we're talking about here today, mobility and really muscle health, animal-based proteins have better protein quality than plant proteins. This is largely driven by their essential amino acid content, which leads to a better amino acid score. And so when we talk about muscle health, when matched for protein and energy intake, egg results in greater net protein balance than a similar meal of cereal. So in other words, when matching for protein and total energy content, a meal of egg is going to have better effects on net protein balance than a meal of cereal. And the bigger effect is actually on protein breakdown. Egg led to a greater decrease in protein breakdown than cereal, which means less protein was being broken down, meaning more muscle protein was being retained, ideally leading to, better maintenance of muscle health, things like muscle mass and strength. You advance the slide, please. And that wraps up my dietary protein. So there are three elements to it, really, folks. That's dietary protein quantity. We want at least zero point 0.4 grams per kilogram per meal, or about 1.2 grams per kilogram per day. Dietary protein distribution, that's getting enough protein at each meal. And dietary protein quality, that's getting complete sources of protein. Most of those are going to be animal sources of protein. Now, some plant sources can be combined, something I can talk about if I have extra time, to make complete proteins, but we'll leave it at that for now. Moving on to inflammation and aging, it's well documented, right, that aging is associated with increased markers of inflammation. In fact, there's the inflamma-aging, right, model of aging, where inflammation is the main driver of aging. Will you advance the slide, please? It turns out that another component, or a component of our dietary intake, is also a component or a regulator of our inflammation. So omega-3s and omega-6 fatty acids are both polyunsaturated fatty acids. And generally speaking, they're used for two different classes of hormones. I shouldn't say classes of hormones, two different functionalities of hormones, but one class of hormones. The class of hormones are the eicosanoids, and omega-6s are going to be synthesized essentially into pro-inflammatory eicosanoids. Omega-3s are going to be synthesized into anti-inflammatory eicosanoids. And so the more important thing here is the ratio of these. The omega-3 to 6 ratio is a determinant of someone's inflammation. You advance the slide, please. So this is an example. I'm not going to spend a lot of time here, so sorry, Amanda, about that. But here's an example of the different eicosanoids that can be synthesized from either omega-6s on the left or omega-3s on the right. And you can see the physiological effects of the omega-6s are mostly bad. We're talking about, inflammatory, pro-arrhythmic, activating platelets, so increasing clots, whereas, the omega-3s are having the opposite effect. They're going to be stabilizing heart rhythms, anti-arrhythmic. They're going to be platelet inhibitors, preventing clots. They're going to be vasodilatory and anti-inflammatory. Will you advance the slide for me, please? So getting back to muscle health, it turns out that omega-3 supplementation, think fatty fish oils, actually increases muscle strength in older adults. So this wasn't done in the context of people who were necessarily deficient, so to speak, in omega-3s. This was just supplementing with omega-3s in the context of resistance exercise. It's a meta-analysis, so this is several different studies. And as I mentioned, this actually led to increases in muscle strength. So increasing omega-3 intake is an important way, or another way, that we can increase muscle strength, decrease disability. You advance the slide, please. On top of that, for a lot of the other reasons I mentioned on the hormone slide, the fact that some eicosanoids are, activate platelets, whereas others inhibit them, omega-3 intake is also related to mortality. So as we have increased amounts of omega-3s, that would be the third tertile. That's the greatest intake of omega-3s. We see that these people have a significantly higher survival rate than people in the lowest intake of omega-3s. So beyond, right, muscle strength, because we are here focusing on muscle strength, but probably mortality is the most important outcome measure. Here's really clear evidence that omega-3s really are important for reducing mortality. Will you advance the slide, please? Moving on from omega-3 fatty acids, we're going to be talking about, well, of course, vitamin D, as you can see. So the big issue with older adults is that older adults produce less provitamin D in response to sun exposure. And in fact, actually, I misphrased that, because I should have said the bigger aspect is a lack of the 1-hydroxylase enzyme. So for those who didn't know, vitamin D is actually an active hormone in its, final version. That's the 1,25-dihydroxycholecalciferol, or calcitriol. Calcitriol enhances mineral absorption. It's also involved in bone deposition. And so as we get older, older adults express less of the enzyme that actually converts the less active form of vitamin D, 25-hydroxyvitamin D, into its final version, 1,25-dihydroxyvitamin D, for its activation. So decreased levels of this essentially lead to chronically low vitamin D levels. And on top of that, I should have said, older adults actually have less of the precursor for endogenous vitamin D production in their skin. Will you advance the slide for me, please? So in addition to vitamin D, the issues we have with that as aging, we're probably familiar with the effects of aging on bone health. right? Basically, bone health peaks at sometime in our middle age, or I guess early middle age or young adulthood, stays elevated for a while. After about 40 or so, we start to slowly lose bone mass. Women, instead of men, because of menopause, actually lose a greater amount of bone mass because estrogen increases the expression of vitamin D binding protein in addition to other functions related to bone health. So women are at increased risk of bone-related health compared to men because they have lower overall bone mineral mass. They just have less total skeleton. And then number two, right, they have typically go through menopause. This decrease in estrogen is going to lead to decreases in bone health. So when we think of vitamin D, we usually think about bones, right, and aging. And so vitamin D is critically important for maintaining this bone mineral density, which is related to also being mobile, right? Because if you have poor bone mineral density, you might have a fracture. And of course, that's not, well, I don't even know what to say about that. That's a bad thing, right? We definitely don't want fractures. Can we advance the slide, please? So vitamin D isn't just involved, though, in bone mineral strength or mineral reabsorption. Vitamin D is actually involved in a host of, I should say, a myriad of functions throughout the body. Every cell in the body has a vitamin D receptor, so there's a whole lot of functionality with vitamin D. But one of the more surprising aspects is that vitamin D actually enhances muscle strength. So if somebody's vitamin D deficient, we see decreased mTOR expression that leads to decreased protein synthesis. We also see increased things like the FOXO-transcription box, which leads to muscle atrophy. So vitamin D deficiency can also be a thing that drives sarcopenia. Will you advance the slide, please? Well, it turns out that vitamin D supplementation, in light of that, actually increases muscle strength levels, even in just healthy individuals. So even folks who aren't vitamin D deficient, if we give them a vitamin D supplement, it actually enhances their muscle strength. Will you move it one forward for me, please? So a lot of times people tell me, hey, get outside and make some vitamin D. Well, we got a lot of diversity across the country here represented, but if you live above the 37th degree latitude in the United States, you actually can only make vitamin D from May to October, and it might even be worse. So in Grand Forks, we're right near the top of North Dakota, so right near Canada. So I would say that our time period to make vitamin D is probably more like maybe June to September. I'm guessing there, but it can't be very good. So the issue here is if you're getting outside anytime between May to October, the sun's not high enough above the 37th degree parallel to actually produce vitamin D. And that's problematic because we really can't be telling people to get outside. Will you advance it one more for me? In addition to that problem, which I would consider to be the biggest issue, here's a bunch of other issues about making vitamin D from sunlight. Number one is an increased risk of melanoma because, well, sun exposure, ultraviolet light, in particular ultraviolet C light, right, is damaging to our DNA. In addition to that, folks oftentimes have difficulty actually getting outside during the middle of the day when the sun is high enough in the sky for vitamin D to be produced. For instance, right, I work as a professor. I'm not getting outside a lot during the middle of the day. I mean, maybe I should be, but I'm not. You get lower lower production from sunlight if you have darker skin when it comes to making vitamin D. So melanin, the pigment in our skin, absorbs the ultraviolet B light needed for making vitamin D. So if you have darker skin, you actually need to be in the sun longer than someone with fairer skin to produce the same amount of vitamin D. We produce less vitamin D as we get older. That's due to less 7-dehydrocholesterol levels in the skin. And the biggest one that I really mentioned already is that we need to be in the right place at the right time in the United States. If you're above that 37th degree latitude, you really can't make vitamin D during most of the year. Will you advance the slide for me, please? And so for that reason, before I talk about vitamin B12, I actually generally, this is against most dietitians' playbook, but I would recommend a vitamin D supplement for most people simply due to limited access to foods that are rich in vitamin D. The best sources of vitamin D, folks, outside of sun exposure would be fatty fish in food. And frankly, especially in the middle of the country, we're not eating enough fatty fish to get to the vitamin D levels that we need. So generally, I do recommend a vitamin D supplement. This is the last nutrient that I'll be talking about today, though. This is vitamin B12 or cobalamin. Deficiency of vitamin B12 results in megaloblastic anemia and can also result in neurological impairments as well. And the critical thing here is as we get older, we actually absorb less B12 in general. And this is due to reduced production of stomach acid. And that's further magnified, right, by heartburn medications. Somebody's using something that limits stomach acid secretion, they're going to have even decreased vitamin B12 absorption. And that's because vitamin B12 has a fairly complicated digestion and absorption, but basically B12 is bound up in other proteins when we digest it. We need the stomach acid to free B12 from the proteins that it's bound to in order for us to absorb it. Will you advance the slide for me, please? Well, it turns out that low amounts of B12, a B12 deficiency, is related to low appendicular skeletal muscle mass, at least in a sample of Korean adults. This is the best evidence I could find, folks, about B12 and specifically sarcopenia. But here's good evidence, relatively good evidence, that B12 also drives things like muscle strength. Recall, right, that earlier on I mentioned it's the neuromuscular system. Well, vitamin B12 is needed for things like nerve myelination. So no vitamin B12, you might have issues in, neurological issues, I should say, leading to decreased muscle strength. And will you advance the slide one more? Okay. So older adults need increased nutrients. That's really was what I was trying to drive home there, folks. Older adults need more protein. They need more vitamin D. They need more vitamin B12. They need a greater amount of omega-3s. However, older adults actually expend less energy doing these same exact activities. This means older adults need to intake less energy. In general, it's best for most of us to be in an energy balance. This is a state where we're expending close to as much energy as we're intaking. One day varies, might do more on one day and less on the next day. But in general, that's what's going to benefit people's health. An increase in energy, leading energy intake, leading to positive energy balance, right, could result in obesity. Negative energy balance, you could even starve, or you could have other issues like decreased muscle mass. Will you advance the slide for me, please, Amanda? So as I mentioned, older adults have greater intakes of protein, calcium, vitamin D, and vitamin B12. But they have less total energy needs. This means that empty calories are a big concern for older adults. What exactly is an empty calorie? An empty calorie, by definition, is a calorie or a source of energy whose only nutrient content is, in fact, that source of energy. So added sugar is the best example of this. Adding sugar to a food doesn't increase the nutrient content of any food except for in the capacity that it increases its energy content. And so anything with added sugar is going to equal empty calories, a big concern, again, for older adults. You advance the slide. Well, it turns out that as we get older, another reason why getting older is not a great time is not only do we lose muscle mass and strength, but as I mentioned a little bit earlier, we also lose our ability to taste. So this is the the taste intensity scores by different age groups. So we have 18 to 36 years, 37 to 50 years, and 51 to 80 years. And we can see across different tastes, bitter, sweet, salty, sour, and umami, that taste decreases. But what does this mean for us? This means that added sugar intake might actually increase. Will you advance the slide for me, please? And this is actually modulated by sex. So women in general are actually better tasters than men. So men tend to taste worse than women. You would advance the slide for me, please. And so because our perception of taste decreases as we age, older people, generally speaking, prefer food that actually tastes stronger. They taste less of the intensity with the same amount of stimulus. So older adults prefer two things that lead to problems from a dietary standpoint. The big one for our webinar here today is excess sugar intake. This increases empty calorie intake. That added sugar really doesn't provide a benefit. Doesn't increase protein, doesn't increase omega-3s, doesn't increase vitamin D, doesn't increase vitamin B12. The other one is excess sodium intake. That's a conversation for another day. But the point is, older adults have both we all have the ability to taste salty and sweet, but we lose that ability as we get older, thus preferencing us to prefer more sugar and salt. Advance the slide for me, please. So to summarize, aging results in a loss of muscle mass and strength. This is problematic, right? In addition to that, dietary intake also decreases as we get older. This is due to, decreased ability to chew, and in addition to that, maybe decreased motivation, right, to eat as well. Older adults, though, actually need greater intakes of certain nutrients, namely protein, omega-3s, vitamin D, and vitamin B12. Advance the slide, please. This is more me highlighting why these reasons are. So with protein, older adults need more protein due to anabolic resistance related to both exercise and dietary protein. Older adults need more omega-3s to counteract the inflammation associated with aging. Older adults need more vitamin D because, one, they express less of the enzyme capable of converting vitamin D into calcitriol, and two, they have less synthesis of vitamin D in their skin. And finally, older adults have increased vitamin B12 needs due to decreased stomach acid production, an issue that can be compounded, right, by using things like antacids. Next slide, please. And our final summary slide here. So energy expenditure decreases as we get older. So this means older adults actually need less energy intake, but more total nutrients. This kind of direction or order, if you will, to eat more nutrient dense foods is complicated by the fact that older adults actually taste worse. That worsened taste leads to excess intake of particularly added sugars, which again are empty calories, only providing energy and not nutrients. And so older adults really need to focus on consuming nutrient dense foods, which would be nutrients divided by calories, again with an emphasis on dietary protein, omega-3s, vitamin D, and vitamin B12.
Okay, so there's a lot of information there, but we're going to try to process it through this case application again. So I probably won't read through it again, just kind of hit on some of the high points. So some osteoarthritis, limiting mobility, also having some of those changes in cooking, gardening, some of those hobbies and activities during the day, which is also affecting Mrs. Smith's diet. And currently she's eating mostly the convenience foods and processed meals, which are very common out there in our world today. And she lives alone. So considering that in her meal preparation, along with the limited mobility, decreased strength, some weight loss, weakness, fatigue, and also some joint pain. So let's go to the first question here. And I think what will work best is going into the chat. And if you're able to put some answers in there as we go. The first question is, what are the key nutrition and mobility factors from the case example? So if you need to, how about I can go back to kind of remind you here of the case. So go ahead and type out some of the key nutrition and mobility factors for our Mrs. Smith. I'll give you a few minutes. Okay, good. We're starting to get some answers coming in. So I'll just read them out loud as we go. So we have skipping meals, snacking, some poor nutrient contents, exactly the processed foods. Like we just talked about, that nutrient density is really important. Also, the high salt is very common in those processed meals. The mobility impacts, along with comorbidities, weight loss. We have some repetition there, so that's great. Decreased activity tolerance, right? So it's harder to maintain that mobility and strength. Not enough omega-3s. Reduced fresh foods. You know, it sounds like maybe in the past she was good with gardening, but wasn't able to keep up with that because of her mobility. And in the past, maybe that was a way she was able to get some of that fresh food availability for herself, but now maybe not as able. And then the whole the cooking process being limited with pain and being alone. I like how Mary mentioned the less socialization. Again, both with mobility and you know, much of our lives are a social process, even going out to eat and socializing with friends. So that's an important factor of quality of life. We have arthritis, weakness, decreased D, excuse me, some of the weight loss. So you guys have definitely hit most of the points there. I'll just bring about what we had come up with, and I think you guys hit all of these points. Also with the, I think somebody mentioned it with the cooking process, just how the OA and the mobility might play into that, and either the endurance or tolerance or even desire to want to do that process of cooking because of the pain or limited tolerance, and being alone too can be a factor with that. So anything else you want to mention, Nathaniel? I think that was most of it.
Yeah, no, not really. I think I just reiterate kind of how hard it is to, even outside of aging, being alone is a great difficulty for good nutrition intake, because there's a lot of things that go on there. But basically, people don't want to cook for just themselves. And one of the ways to phrase that are, if you make food for yourself, you're probably making, a recipe that might serve, let's say, four, maybe even six. Well, then you're having the same food, for the next maybe 2 to 3 days. And you'll find that generally people are not very happy or excited about doing that. And I think that loss of kind of novelty, coupled with the pain in the butt aspect of cooking, if you will, makes it really hard to make meals at home. And when you're not making your own meals, usually you rely on convenience or processed food. And so that socialization really is more important maybe than we give it credit for.
Mm-hmm. Yeah.
And yeah, we got a great comment here. Eating becomes a chore and it's not enjoyable.
Yeah.
That's exactly right. That's what can happen if you live alone. So I think that, that sometimes we focus a lot on, telling older folks you should eat this and you should eat that, when maybe the best intervention really is getting them in a group setting where there's socialization and food. But we'll leave that there.
Okay, let's go on to the next question. So what are you aware of in your current practice with the types of screenings or assessments that you're either currently doing or want to do, or for what we just discussed with the nutrition or the mobility limitations? So we'll do the same thing here with putting that in the chat. So what type of things do you do already, or are maybe are aware are out there? Give you another minute. Go ahead and add in the chat any mobility screens that you do, strength screens. Any nutrition screening or assessment? Okay, so we're starting to get some answers here. So looking specifically at muscle mass, nutrition studies, we'll talk about some specific ones. If anybody has any names of assessments that they use. Again, screening for fall risk, yes. Strength screens. Specifically strength testing, the MOCA for cognition, looking at daily habits, ADLs. Let's see, Lindsay says, any concerns to get into a PCP or ask for a referral to see a nutritionist? A lot of times there ends up being a dental issue. Yeah, getting down to the root cause of the dietary problems is really important. Trying to avoid some of the protein drink supplements, and give information about food shelves, that food accessibility, exactly. Okay, so the steady screen, geriatric depression screen, grip strength, yes, perfect. You've got a few of those, the sit to stand. So you guys definitely hit the overall big picture. I'll discuss some of the more specific ones. So you might be familiar with the sarcopenia and frailty assessment score. That one can look at identifying people who are at risk for that muscle weakness, looking specifically at grip strength, which we've discussed already. The chair stand, sit to stand 5 times in a row. I'll move on after this. I'll show you some of the cutoffs or the norms for these that you can look at. Gait speed is another one. So specifically the chair stand and the gait speed, those are looking at those physical assessments like we talked about when we're looking at diagnosis of sarcopenia. The short physical performance battery, that pulls everything together. So that includes balance, it includes the gait speed, and then the chair stand together to give that overall score. And then the DEXA scan, looking at bone density, nutrition screens. So a couple that are more of the common ones are the mini nutritional assessments. I have that one included here. And then the simplified nutritional appetite questionnaire. And I'm glad that somebody mentioned just the information about food accessibility. So looking at, there's a USDA screening for the food security. How available is that food for them? So this algorithm just talks through how the diagnosis of sarcopenia can work through. So a lot of the assessments we just talked about, or the screens, are included here, most specifically looking at strength and physical performance. So that grip strength and chair stand, looking at the norms for the age groups there. I'll show you those cutoffs here in a second. But if they're below the norms, that may indicate the sarcopenia requiring some further assessment. And I would say these are not, it's not completely linear. I've had patients in the clinic who I will look at grip strength and gait speed, overall functional, because we need to see how they're participating in their daily life as well. But all of that information can be pulled together, and then working with the interprofessional team to address the impairments there. But these are the cutoffs that I was talking about. I think you might find these really helpful. This comes from the European Working Group on Sarcopenia. So you can see what we just talked about here with the muscle strength with chair stand, grip strength, and some of the cutoffs here specifically. And looking at probable versus sarcopenia, and then more into that severe sarcopenia. So that physical performance can really identify those who are more in that severe sarcopenia range where we need to work multidisciplinary to address that. Again, the mini nutritional assessment here, it goes through questions regarding a loss of appetite, chewing, swallowing difficulties, any weight loss, mobility, psychological stress, neuropsychological problems, and looking at BMI as well. But this is a good way to screen for that, so you can identify if any additional referrals are necessary. And then the snack here is just a few questions to have them rate their appetite, if they feel full, how the food tastes, like Nathaniel was talking about with that change in taste, and kind of their overall dietary habit can give you an indication if they're getting adequate nutrition here. There's the USDA Food Security Questionnaire. Honestly, before I started doing research into all of this, I was not aware of this. So I have been learning things along the way, and it's a really important idea to emphasize just how is that food available? We talk about getting the right kinds of food, but do they even have the availability or accessibility of that the food options? You can also include mobility in there. Are they able to go to the grocery store? Do they have transportation to get there? Are they able to carry it? They might not buy what they need because they're not able to get that food into the home. There's many options out there for other getting that food to them, and we'll talk about that too. But oh yes, and also Lindsay mentions where they can store the food as well. If we talk about, in our homes, we have cupboards high, we have them low. Are they able to reach what they need? Maybe their children do their grocery shopping for them and they have the food availability, but they can't get to it. Something good to consider. And then the last question here, what would be some other referrals you might give for this person? And I might actually, since we're getting close to time, I guess I talk more. We'll just roll right through it. Yes, and people are starting to come in with some things here. So dietitian, public health, PT, exactly, senior meals, community meals. Yep. We also have Meals on Wheels here. I know Nathaniel mentioned previously the NDSU Extension Service. There's a couple links here for different programs. Do you want to talk about those?
Yeah, so I used to work for NDSU Extension. We don't talk about that at UND. But there's good programs online here about Nourish Your Body. This is a series of essentially little lessons, if you will, for older adults about the importance of eating. And they're blocked off by like subject matter. So like nourish your eyes and nourish your brain and nourish your muscles as well. And then Cooking for One or Two is a great program designed for recipes, right, for older adults, as you might guess, where there's just one or two people.
Yep. And then I'll just briefly go through dietitian, OT for prep management, and maybe how to keep doing their hobbies or activities of daily living. PT for strength, I think somebody mentioned that. Even a social worker to help facilitate some of those other resources. And if the doctor needs to be more involved as well with further imaging or looking at maybe other reasons for unintentional weight loss. Something to consider there. Lindsay mentioned some insurance does provide transportation and certain monetary amounts to get healthy foods. I think, was it WIC that just approved additional approval for fruits and vegetables? I know there was something recently with one of the programs that they're approving more healthier foods. So that's great for some of those programs. And yep, Bethany says it was WIC. Thank you for confirming that. But let's come back here. That's essentially our presentation. Thank you for your time.